Start now.
Good afternoon, everyone, and a very warm welcome to the second session of the third series of the Standard Treatment Guidelines conducted by NHSRC in collaboration with the Delhi Society for Promotion of Rational Use of Drugs. Today, we have with us our esteemed faculties, Dr. Pawan Kumar sir, who is the Additional Commissioner and in charge of Maternal Health and Immunization, Ministry of Health and Family Welfare, and Dr. Shakun Tyagi ma'am, Professor, Obstetric and Gynecology, Maulana Azad Medical College, New Delhi. I would also like to welcome Dr. Jayan Srivastava sir, Advisor, Quality and Patient Safety Division, NHSRC, and Dr. Sangeeta Sharma ma'am, President, DSPRUD. The topic for today's session are challenges in ANC in pregnancy by Dr. Pawan sir and anemia in pregnancy by Dr. Shakun Tyagi ma'am. With this, I would like to request Dr. Jayan Srivastava sir to please address the audience.
Thank you, Aman. And at the outset, on behalf of NHSRC and also on behalf of Delhi Society for Promotion of Rational Use of Drug, we extend a very warm welcome to Dr. Pawan Kumar, who I know he has many competing priorities, and as such, maternal health division in the ministry, and with the added responsibility, he is heading the immunization effort also in the country. Many things are there in his plate, but still about 2 weeks back when I requested him to be a resource person, to be a faculty for today's session, and he very kindly and readily agreed. We are extremely grateful to him. And also the second faculty, Professor Shakun Tyagi, who has been in fact a busy obstetrician at Maulana Azad Medical College, have kindly consented for this. And of course, the driving force behind this whole initiative, I would say the colleague only, Professor Sangeeta Sharma, with whom we have been working together for many years now, when we started before even the STG series. So the background has been that like one side, all of us are working for the betterment of the health system in the country, whether it is the private or government health system or anywhere. But once we are, the whole focus of the government is that the people should receive the quality care. And till now, the focus on the quality, when we spoke, it has been primarily focused on that how the patients are received in the facility, registration process, waiting area, and how much time how much time is taken for the consultation, availability of the drugs, diagnostics, etc. But the main challenge has been on the clinical dimensions, particularly when the government has also taken a decision that at sub-center level, there will be a fully operational facilities, which is known as now Ayushman Arogya Mandir. Those of you who are not conversant with the terminology being used in the public side, public health system side. And in this Ayushman Arogya Mandir, there is a community health officer who not necessarily having a qualified MBBS degree per se, but normally they are having the BSc nursing qualification with the added mid-level course. And traditionally also, we may recall that for the primary healthcare level, the conduct of the ANC and detection of the high-risk pregnancies have been primarily the responsibility of multipurpose worker female, and who is our field level functionary who has been there. In addition, with the government's effort towards the UHC, and in that direction, there is a whole lot of efforts are going into strengthening the primary health care, so that the patients who, not the patients, but the mothers and the patients, those who need the specialized care get referred to the higher level at the secondary care, that is at the community health center, and further upward with this strong linkage. But if we are there, and let us remember that our primary health doctor also, he's all alone, hardly having any opportunity, any avenue for the clinical enhancement, coming to know that what are the latest developments which have been happening in the field, because we all agree that the medical field, the practice of the medicine has been ever evolving. And for the and also some kind of refresher training even for the people who are there in the district hospital or in a corporate hospital, who are busy practitioners who are there. They hardly get time to go through the latest clinical protocols. So for strengthening the clinical care in general, almost 2.5 years back, we started this lecture series in collaboration with Delhi Society for Promotion of Rational Use of Drug, which is being driven by Professor Sangeeta Sharma and the colleagues over there. And initially we thought that we will run one full year this lecture series and subsequently stop it. But the response of the participants from the field has been really encouraging. And this also we have been evolving every time that what could be the better way to connect. So initially the 2 lecture series were run, then subsequently we thought that let's have something for our primary in a focused way for the primary healthcare practitioners also. And we thought that to speak on this topic, there will be no better person than Dr. Pawan Kumar to speak on this subject, that how the care of the mothers, care of the pregnant women who are there in a remote corner, and what are the early danger signs, touching upon certain basics. Then of course, to have the continuum of care, there is a distinct role for the secondary care facilities, for the tertiary care facilities, and that is where we requested Professor Tyagi to deliver on the higher level of the care. In which situations these mothers are required to be referred to the higher level, what could be the possible ways and means to tackle the problem should the lady have this any potential, any say early signs or any complications to happen. Anemia is also one of the common problem. I don't have to reiterate. So with this background, this session has been arranged today, and this will be my personal request to all the people, those who have joined, that please write down your queries in the chat box, and at end of the sessions, we will try to answer each and every queries. And this also somewhere to get a feel that where do we stand today. There is a pre-test questionnaire, pre-training questionnaire and post-training questionnaire as well. So I won't take much time because I'm also very keen to hear from our eminent faculties. I will stop over here and request Professor Sangeeta Sharma and Dr. Pawan Kumar to conduct the first session jointly. Thank you.
With this, thank you so much, sir. With this, I would like to invite Dr. Pawan, sir, to conduct the next session. Sir holds various degrees like MBBS, MD, DNB, etc., to name some. He has over 24 years of experience in the public healthcare management and has published over 75 publications in various national as well as international journals. Sir is also an associate editor for the Journal of Advanced Research in Medicine, treasurer of Indian Society of Hospital Waste Management, a life member of other professional bodies like IAPSM, IPHA, IMA, AGI, etc., to name some. He is also a recipient of more than 19 awards at the national and the state level, and a recipient of Excellence in Public Health Award in 2017. Sir is also awarded with an Ambassador of Peace for Universal Peace Federation by the Social Council of United Nations in the year 2021. We welcome you, sir.
Thank you. So may I start?
Yes, sir, I'm sharing your presentation.
Yes, please.
So thank you very much, Dr. Jain Srivastava, Dr. Sangeeta Sharma, Dr. Shagun Tyagi, my other co-faculty for this important series about the public health interventions which are happening in the country and the management of anemia and the pharmacotherapy of anemia. So being a first speaker, the job assigned to me is regarding challenges which we face in antenatal care for our mothers in the country. And at the outset, I'm very thankful to Professor Dr. Jain Srivastava and Dr. Sangeeta Sharma to organize such a beautiful series of events for last 1 year. And we are reaching to the remotest areas in the country, the hard to reach tribal areas. And this virtual mode in such a beautiful platform where we are need not to be physically available, but we can take advantage of dissemination of the public health interventions which are happening in the country. So going forward with the agenda for today's talk, which I will be speaking for 35 to 40 minutes, is about the antenatal care. And I have been told that the CHOs, the primary healthcare provider, which are there in the country, they are being online today for this important topic, which is of a very public health importance in the country. And we'll be discussing about the maternal mortality ratio, then what are the important causes of maternity mortality ratio in the country, ANC visits, how many ANC minimum visits they are required, and what are the challenges we face in our country, and what are the key strategies which has brought by the Ministry of Health and Family Welfare, Government of India, and how we can overcome these challenges. And I'll touch upon the few best practices about the ANC and looking after our mothers which are pregnant during those 9 months. Next slide, please. So if we see the maternal mortality ratio trend in the country, next slide, please. Yeah. So if we see the global MMR in the and the vis-a-vis the country's MMR in our context, in 1990s, the MMR of the country was 556 maternal death which were happening per 100,000 live births, means 1 lakh live births. Whereas the global level, there were 385 deaths were happening. But the fall which has happened, the fall in maternal mortality ratio, the trend where there is a decrease in the maternal mortality ratio in the country, the fall is much steeper and faster in Indian context. If we see on the right side, the global MMR decline is just 42% from 1990s onwards. But if we see the fall in MMR in the country, it is 83%. This means whatever the strategy is, the actions, the action points which has brought in the country, they are all working, and we are moving in a positive direction. And if we see the national health policy targets and the SDG targets of reaching 70 MMR by 2030, almost 8 states they have already achieved the MMR less than 70. To name the Kerala, Maharashtra, Andhra, Telangana, Tamil Nadu, Jharkhand, Gujarat, all have a MMR less than 70. And this is a hallmark, and this is the most important indicator for the maternal health in the country. Next slide, please. If we see the trend of maternal mortality ratio into this in our country, and the benchmark is SRS, the sample registration system. In 2014 and 16, the MMR was 130, and there is a gradual fall in the MMR. And by the SRS of 2018, which is the latest SRS which is available, we are standing at MMR of 97 in our country per 1 lakh live births. And the trajectory by which the MMR is falling in the country, which are we are very pretty confident that by 2030 we'll be able to achieve our SDG target of 70 per 1 lakh live births. Next slide, please. For this reduction in MMR is not a 1 day or 2 day, it's a gradual phenomena. And as a public health intervention, Government of India had brought series of documents, guidance, interventions for all state and UTs. To name few, in 2005 we brought a JSY scheme, then in 2011 we brought JSSK scheme, then Pradhan Mantri Surakshit Matritva Abhiyan, then Lakshya about the quality assurance during the antenatal period, then we brought a midwifery guidelines to have a normal deliveries by the professionals which are well qualified for having a respectful maternity care in the country. Then we brought a Surakshit Matrutva Aswasan is an umbrella program for the country. Then extended PMSMA, where almost 25 high-risk pregnancy conditions they have been incorporated, and through the IT-based platform, we track those high-risk pregnancies. Then postnatal care, the Lancet and other journals, they speak that more than 30% death they happen of a maternal consequence in the postnatal period also. So we have brought a postnatal care guidance document also. Then we have brought a series of documents for the midwifery care in the country. And in 2024, we again brought a mentoring guidelines for our midwives in the country. And apart from this, we have strengthened our healthcare system at the primary and secondary care in terms of MCH blocks, the delivery points, the ICUs, HDUs, capacity building, CMOC, life-saving anesthetic skill, the skill birth attendant guidelines, then universal screening for the high-risk pregnancies and gestational diabetes, HIV, syphilis. And we envisage to have that each maternal death which is happening in the country, the audit should be done. Is a kind of audit where we should know what are the causes, why death of those mothers they have happened in the country which were pregnant, though it is a physiological phenomena, then abortion care, and how to look for all these things into the country. Next slide, please. If we see the important causes of maternal mortality ratio in the country, so if we see the SRS data, we have a two set of data. This one is 23 years back and the latest of 2014 and 19. The major cause of losing our mothers in the country during pregnancy is the hemorrhage, followed by PIH, pregnancy-induced hypertension, the sepsis, abortion-related problems, the obstructed labors. The main causes remain the same, the thematic areas remain the same, but in the last many years, the percentage have changed. But all these causes, they are preventable causes of maternal mortality rate in our country. And if we do interventions, evidence-based interventions, these causes of maternal mortality, they are preventable for our country mothers. Next slide, please. If we see importance of antenatal care during for reduction of MMR, first is to detect health issues or high-risk pregnancies during the antenatal care. As being iterated in the introductory discussion also, the anemia is the most important, which leads to hemorrhage, and then hemorrhage happens, then the mother becomes more anemic, and that she can go into the shock also. Then followed by pregnancy-induced hypertension, the diabetes, and during ANC, we need to monitor the growth and development of baby also, and that is important importance of good ANC care. Then we have to prepare our mothers, these pregnant ladies, for institutional deliveries, and we have to do their counseling, whatever the benefits available in the government setup for these 9 months, where they can avail the free of cost facilities in our health facilities, and this counseling for the breastfeeding, for the antenatal care, for the family planning services after once the delivery has happened, and the nutritional care of mother as well as the baby. So these 9 months of antenatal care, they are very important for the mother to have a healthy outcome at the end of 9 months. And this is ANC, the time is an opportunity to avail this opportunity by our primary healthcare providers in the country level to educate these mothers, the women and their families about the contraceptive measures, because too many pregnancies, too fast pregnancies, they all leads to increase in the maternal morbidity, mortality, which in fact leads to reduction into early neonatal mortality, infant mortality. So these 9 months, they are very important for the mothers in the country. Next slide, please. So next, please. If we see the ANC status, how the ANC, I'm just referring the National Family Health Survey data of 2019 and 21, because this is survey data which is globally accepted. So if we see the average of India is 70%, the percentage of women who have first trimester ANC visits in our country is 70%. And if we see the bars on the left side, many states and UT like Ladakh, Kerala, Telangana, Jharkhand, Haryana, Punjab, all they have 80s, 90s, the ANC first coverage. But there are many challenges like in Uttarakhand, the Meghalaya, the northeastern belt, the UP, where the first ANC checkup is less than 70% as per this survey. Next slide, please. If we see the 4 ANC checkup, if the SDG target to have a 4 or more ANC is more than 75%. But if we see the survey of 2019, 21, it is just hovering 58, 59%. But many states and UTs, they are performing better than the national average, but they are still challenged in the northeastern states. Tripura, Meghalaya, Assam, Jharkhand, Arunachal, Bihar, Nagaland. These are the states where they are less than the national average. So these are the challenges why we are not able to achieve more than that. But if we see the HMIS data, that is doing pretty well, maybe 80%, 85, 88%, and the average is hovering between 80 to 90% for the first day and the 4 ANC checkup. Next slide, please. So if we see the national average of ANC is around 70%. So I'm showing the pictorial or Indian map. And if we see on the right side, the average, if we see the southern states, they are doing better than the northeastern, the EAG states, where the average of first ANC is around 80%, like Telangana, Andhra, Maharashtra, Karnataka, Kerala. But if we see the middle picture of Indian map, which depicts the northeastern states like Assam, Arunachal, Nagaland, the average is around 62%. But if it's the empowered action group states like Rajasthan, Madhya Pradesh, Uttarakhand, UP, Bihar, where the average is around 68%. So these are the depiction of averages of first ANC checkup in the country. Same way, we can move to the next slide for 4 ANC checkups. If we see the 4 ANC checkup, if we see the right side map of the southern state, they are doing better than the northeastern, than the EAG states, where the average of southern state is around 75 plus. But if we see the northeastern state, which is average is around 50%. If we see the EAG states, the average is just hovering between 50 to 53%. Next slide, please. So we were looking at the research and evidence-based data also about the reduction in the maternal mortality ratio in the country, where the quality ANC checkup is there in the country, which is related with the women's education and the wealth. If we see the data of the research, so good ANC checkup help us to have a better ANC and a better outcome of the mothers at the end of the 9 months. And if we see another study of 2024 where the maternal mortality reduction is related with the good antenatal care, quality antenatal care, and the institutional deliveries, because all these parameters, they have a impact on the reduction in maternal morbidity as well as the mortality in the country. Next slide, please. So these 9 months of ANC care, they are very important, which prepare our mother, the pregnant women, for the better and healthy outcome. And during this phase, we are able to detect the high-risk pregnancies also, which have a higher impact on maternal morbidity and the mortality. Next slide, please. So what are the components of a good antenatal care? The today's topic, which is for our primary healthcare providers, the audience which have been connected from remote and other states and UTs. Early registration, as early as possible. When some mother is pregnant, she should be registered in our system as early as possible. Then we need to have at least 4 ANC checkup during those 9 months of pregnancy. And during that period, our system be robust enough to pick up the high-risk pregnancies also. And we have a strategy like PMSMA, the Pradhan Mantri Surakshit Matritva Abhiyan, which is from 2nd months onwards, where the 9th of every month, we from the FRUs or CHC onwards, we have a specialist kind of a OPD, where the CMOC or BMOC doctor or a gynecologist or obstetrician or a trained MBBS doctor who can capture or pick up the high-risk pregnancies. And what are those important factors during that high-risk pregnancy? then 2 doses of TD during that pregnancy, and ensuring iron and folic acids to take care of the prophylactic part of anemia or a curative part of anemia, and the complete history and physical examination during ANC period. That is the most important component of our ANC checkup at the primary health care level. Let it be Ayushman Arogya Mandir, the sub-center, the ARM PHCs, the primary health centers, or a CHCs or village health and nutrition days, where we get an opportunity to take care of the ANC of a pregnant lady in the country. And then appropriate and minimum amount of test, the lab tests which are required during that period. Let it be a hemoglobin, let it be a glucose tolerance test, let it be a urine albumin, a sugar examination, HIV testing, or a VDRL test, whatever is required during those phases of pregnancy. Next slide, please. So this is the schedule of our ANC in the country. The first visit should be as early as possible within 12 weeks, that means the first trimester. And the second visit should be ensured between 14 to 26 weeks. And the third visit between 28 to 36 weeks. And the fourth visit between 36 weeks and terms. As the country's programs dictates and ensures that at least 4 ANC checkups, at least one in each trimester, should be ensured by our primary healthcare professionals. And last ANC checkup just before the term or before the pregnancy. This is for the normal mothers which are pregnant. However, during the PMSMA, if we are able to detect any mother with HRP from second trimester onwards through our targeted intervention of PMSMA or extended Pradhan Mantri Surakshit Matra Abhiyan, we have envisaged 3 extra ANC visits for those follow-up the high-risk pregnancies, and tagging those mother of high-risk pregnancies to one of our health facility, let it be a CHC or a FRU, where the birthing planning can be done for that pregnant mother, so that at the end of 9 months, we are able to have a healthy outcome and we are able to handle those challenges of high-risk pregnancy during that period. Next slide, please. So during the first ANC checkup, the high-risk conditions and proper planning for adequate care is being done in the country through our healthcare providers, let it be a community health officer or auxiliary nurse or midwife, and then having a MCP card during and safe birthing booklet to be provided, and all whatever the minimum required parameters are required during the ANC in the first trimester, that should be counseled to the mother, and ensuring the first dose of TD vaccine during that time. And then from second trimester onwards, the prophylactic part of iron folic acid, or the mother is anemic, then curative part of the anemia should be taken care of, and ensuring the PMSMA visits, which is happening at the 9th of every month in different parts of the country, from FRUs, CHCs, or facilities where we have availability of a basic emergency obstetric and newborn care, the BMOC trained doctor, a CMOC trained doctor, and then micro birth planning, and ensuring again the PMSM or extended PMSMA visits from second trimester onwards, which are the high risk pregnancies, and the warning signs to be picked up during the pregnancy time, and tagging these appropriate mothers with the FRUs of high risk pregnancies. Apart from these 4 ANCs, I have reiterated that there is a provision of 3 more ANCs, antenatal care, for those high risk pregnancies, and there is a financial aspect also attached with those extended PMSA visits. For the mother also, she is given 100 rupees per visit to the next higher center, as well as the ANM or the ASHA. They are getting the messages also that this is a mother which is being attached with the health facility, high risk pregnancy, and we have to take care of this mother. And along with that, there is a provision 100 rupees for each visit for the ASHA also, to carry that mother to the next higher facility for PMSM or EPSMA visits. And besides this, if the HRP, the mother is having a healthy outcome, and after the 42 days of completion of a postnatal period, the ASHA gets 500 rupees also. So there is a monetary incentive also to encourage the tagging of these mothers to the high risk pregnancy with the FRUs and having a healthy outcome. Next slide, please. So during the ANC period, what are the key elements? Well, the history taking is the most important aspect by our ASHA or ANM or our CHO, which is there at the Ayushman Arogya Mandir, the sub-center, the PSC, where we need to confirm the pregnancy, what is the last menstrual period, any UPT test being done or not, confirmation of pregnancy, then obstetrical history, and then filling of the MCP, maternal child protection card, or MCP, a booklet which is being given at the primary healthcare facility, then any high risk pregnancy in the past or any factor which can lead to high risk pregnancy, and any surgical history in the past, and family history, allergy, and all these needs to be captured during the first trimester itself, and that needs to be followed during the subsequent ANC checkups also. Next slide, please. So during all these ANC, we need to have a clinical examination, and we need to touch our these pregnant ladies during each and every ANC checkup for ensuring the blood pressure checking, having a height measurement, and then weight on every ANC visit, examination of eyes for anemia or icterus, or checking blood pressure, having a abdominal girth measurement, or just seeking any inputs from the mother if she is feeling unwell. So at each visit, our healthcare worker, the CHO, the medical officers, and they should ensure all these components during the ANC period. Next slide, please. So during the abdominal examination of mother during ANC visit, we should confirm the gestational age also by the fundal height. We have to rule out the multiple pregnancies also, and we need to guide our mothers for the first and second ultrasound also through the PMSA during the ANC period also, and through the fetoscope, the FHR, the fetal heart sounds, and auscultate the fetal heart sounds also. So it should be performed at every visit, and the vaginal examination wherever it is required as per the timelines which are being trained training being given to our CHOs and the auxiliary nurse and the medical officers before term, or any PV leakages there, or any bleeding history is there. So these points needs to be kept into our consideration wherever we are meeting our pregnant mothers during our ANC visits, and we should assess these factors so that we can refer to the higher centers. Next slide, please. So what are the minimum investigations which are required during the ANC period? One is the hemoglobin, which is very important, mild, moderate, or severe. This will help us to manage these mothers in a due course of time. At each ANC visit, at least we should do the HP examination. Then at each visit, we need to have a urine albumin examination, which will help us to screen for preeclampsia, eclampsia, gestational diabetes, infection in urine. Then for the diabetes, we need to have a oral glucose tolerance test, and to detect any gestational diabetes or any diabetic condition. Then HIV, syphilis, we have a dual kit which are being given free of cost at all point of care for the ANC checkup. Then tuberculosis screening. So all these, the basic things needs to be done and ensure that the ANC visits when the mother have a contact with the healthcare facility. Next slide, please. So laboratory investigation help us to manage these hemoglobin levels in due course of time, and the RH compatibility also, and the albumin sugar will help us on each visit if any screening or any warning signals for PIH or eclampsia or any gestational diabetes or malaria or anything is there during the pregnancy, and the rapid diagnostic is for the HIV or for syphilis or for hepatitis, all needs to be ensured at the primary care level itself to manage these pregnancy during due course of time of ANC. Next slide, please. So what are the danger signs which we need to train our healthcare workers also, and we as a health professional should be able to capture during the ANC visit? One is the persistent vomiting history, any persistent vomiting, persistent cough, any foul smelling discharge from the vagina, any bleeding history, or PV and diarrhea, or high grade fever during that time, pain in urination or abdomen, any convulsion history, yellowness of eyes, weakness, easy fatigability. All these are very simple things which can be captured during each ANC visit, and these are the warning signs whenever our health professional or healthcare worker comes into touch with these pregnant mother, and they capture these things, they need to be referred to the next higher center. And this is the importance of a good ANC checkup, quality ANC checkup during that time. Next slide, please. So during ANC, we need to have a deworming also for our mothers. We need to have a iron folic acid also for ensuring the normal iron level in the body, in the HP level, and then the different presentations of iron are there. And these will be discussed in the next lecture in detail. So I'm skipping that. Next slide, please. So this all will help us to have a good ANC checkup in terms of any high risk component which is being detected. Let it be normal levels of calcium and supplements during that time. Next slide, please. This will be discussed in the next slide, in the next lecture. So what are the challenges which we have encountered and which we face in different parts of the country? They are because of somewhere in the lack of infrastructure in the hard to reach area or remote area, or where we don't have a delivery points where our mother need to walk more distance, or a transportation is a problem, or a tribal area, the hilly area, like in northeastern states, like in Arunachal, Mizoram, Manipur, or Meghalaya. If we encounter these high terrain areas where really there is a difficult problem from reaching from village to the sub-center or Ayushman Arogya Mandirs by foot, or and getting in the facility of ANC. These are the challenges which we have encountered, and we try to solve these challenges also through different interventions of public health program through the maternal health. And there are few pockets of home deliveries also which pose a challenge for the healthy outcome of mother and the newborn, because the delivery has happened in the home itself. Next slide, please. So to take care of this, the lack of transportation, we have a 102, 108 transportation facilities, and we through the PMSMA we ensure that these mothers they are taken care of the primary health centers, and ASHA or ANM help us to reach to the ANC checkup for these facilities, or we conduct the village health and nutrition there then and there within the vicinity of those mothers in the village itself. And then through the home pockets delivery, there are challenges because the cultural factors are there. So the norms of some of the tribal belts are there, they get delivered. So increasing their awareness for the good quality of ANC checkup, and why the ANC is required through the training, through the IEC, through the behavior change, these components we work for in the country, so that those mothers we are able to mobilize for the institutional delivery. Then poor weather conditions, though they also pose a challenge, and through VHNDs, or we have outreach RCH camps, we try to figure out how we can reach near to the pregnant mothers in the villages or nearby in the block level where we have these RCH camps. Then shortage of healthcare providers. Through PMSMA, we encourage and ask the request Foxy people also in different states, different blocks, or different districts where the private practitioners they are there to devote at least one day in 1 month, that is the 9th of every month, to these our government facilities to have a ANC checkup for and deduction of the HRPs. And the cultural and regional disparities, and we language barriers, so we mobilize our volunteers also, our Suman volunteers also to educate the PRI system, the self-help group in those areas, to mobilize and increase about the good part of the good ANC care, that is the intervention in the remote and hard to reach area. Next slide, please. So for ANC coverage and for the institutional delivery, once the ANC coverage is there, the ASHA and ANM should have a eligible couple line listing in their registers. They should have a pregnancy kits then and there only to detect the pregnancy, the quality VHNDs, the MCP card, tracking and monitoring, community mobilization, and performance-based incentives. Just I've given an example of PMSMA where 100 rupees is given to the mothers and to the ASHAs to mobilize those mothers. So at least we have a ANC, good ANC coverage, and we are able to reach to each and every mother once during the pregnancy time for at least minimum 4 ANCs. Then ensuring those mothers to reach to the facility for institutional delivery, and we have strengthened the delivery points where the basic facilities for conducting delivery is there. Then home delivery pockets we identify. We have a JSSK scheme also where we ensure that the out-of-pocket expenditure for mothers should be near to zero. There should not be any amount which is being spent by the mothers during the pregnancy time. Then the robust HMIS system where each and every ANC and the data for the delivery is being captured into our healthcare system through the HMIS portal, and performance-based incentives for the normal delivery and the cesarean section at the delivery points where through the PIP we ensure some monetary help is given to those PHCs and sub-centers where the deliveries they are happening. Next slide, please. So we have 4 important interventions. That is the Surakshit Matrita Ashvasan, which help us the community participation and grievance redressal mechanism for the mothers and their relatives, so that we have a good quality maternal care in the Suman notified facilities, and the JSSK scheme where the free and zero expenses during normal as well as the cesarean section delivery, and to the newborn till 1 year the free health checkup. There should not be any charges for the food, transportation, drug, diagnostics. Next slide, please. Then through the PMSMA, through the private practitioner, as well as through our government system, through CMOC, BMOC, we are able to give a good quality antenatal care to our mothers through private OBG people, through PMSMA, and we try to emphasize that we should reach to each and every pregnant mother through our all healthcare workers in the field. And we have a very big cohort, that is 2.9 crores mothers, the pregnancies we have every year in the country. So this is a big cohort. Unless until there is a participation of private sector and each and every healthcare level at the primary and the block level, unless until he is well educated about the good maternal health care, will not be able to reach our targets of 70. So this is a joint and combined effort for that. And besides, there is a quality management during the maternity OTs and during the labor rooms, that is through the Lakshya. That is also a good program for the having a quality assurance during the delivery point. Next slide, please. So besides this, there are a few best practices like we have from Odisha, that is called as a Sampurna, where the minimum 2 home visits to all high-risk pregnancies, they are provided preferably during the 5th and the 8th month of pregnancy, and a red card is issued for the HRPs. And then in a local language, and the birth planning is done where that mother needs to go once any kind of a problem happens. Likewise, in the Rajasthan, there is a group antenatal care model approach where a cohort of pregnant women, they are organizing ANC visits at the health facility together with their other activities. And in the Mizoram also, there is an ANC due list chart where the flagging through the red, yellow, and green flags they are done, and each and every healthcare worker knows in case of these warning signals, we need to refer and transport these mothers to the next higher facility. And in Chhattisgarh also, there the mother's picnic is held. As a mother picnic means where all mother of pregnancy in the first, second, or third trimester, they have a get together the next higher facilities, and they learn from each other about the best practices, and they have a counseling during that time about the good nutrition, good food, what are the factors which as a pregnant mother they should look after, and sensitization of the health facilities where they will come to know where they are going to deliver. So sensitization, acclimatization is equally important for our pregnant mothers. Once they in the primary healthcare system, they move to the next higher center. Next slide, please. So this was all about the ANC, the good part of ANC, what are the challenges and how we can address those challenges, and what the maternal health program in the country says about the good ANC checkup, and what is the importance of a good antenatal care checkup, so that at least we have a healthy outcome at the end of pregnancy. And this will not only fulfill the SDG target, but this help us to reduce the maternal morbidity, mortality, and it has an impact on the reduction in the early neonatal mortality, the infant mortality, under 5 mortality, so that the country is healthy through these all maternal health initiatives. Thank you very much, sir.
Thank you so much for giving a very comprehensive overview, and more so, whatever the efforts the government of India has done, the progress the government has made, but still many challenges and different interventions. In fact, there had been few learning, at least personally for me also, though working in the health system, but hearing from you has given a different insight. Really grateful to you. But if my colleagues want to add on something, Professor Sangeeta Sharma or others, they are welcome. Madam, you are muted.
Yeah, thank you, Dr. Pawan. ANC is a very important part. In fact, many of the things you have highlighted are very important. Many of the high-risk pregnancies can be avoided, or they can be managed better to get outcomes. And I think you have emphasized it very clearly. At least 4 ANC visits should be there, and extra 3 ANC visits. And mothers should be prepared for delivery and to avoid postnatal complications. And one thing I didn't know, that was very good, where you had compared states, which states are doing better. Southern states are doing much better, but what is it that in the northern India, or eastern India, or what is it that is lacking that we need to work out? Infrastructure could be one, but I think besides that infrastructure, quality of care is equally important. Whatever services we are providing, whether that is of quality or not. So I think today's session has sensitized the participants well on these aspects. And now Dr. Shakun Tyagi will be talking about the technical aspects of managing anemia, and then after her I'll be talking about the pharmacotherapy. There are various iron preparations available, oral as well as parenteral. Many times we are lost which preparation should be chosen, and when do you see results, and how do you monitor results for your whether it is serving the purpose or not. So here we welcome Dr. Shakun Tyagi. She is a professor in Obs and Gynae at LNJP Hospital. She's been working with us for quite some time and contributing to the standard treatment guideline. Many of you must have seen that book. The Obs and Gynae section, she's one of the lead contributor in the book, and her areas are especially fetal medicine, high-risk pregnancies, preventive oncology, and she's an international fellow from FIGO and DST Fast Track Young Scientist way back in 2009 to 12. Also a member of Community Health and Public Awareness, Safe Motherhood Subcommittee, ICMR, and Intramural Research Projects, etc. She is NB faculty. She has also won many prizes and presented papers, written articles in the journals. Over to you, Dr. Shakun Tyagi. You can see your slides. You can go on full slide mode. Go to full slide mode. Niche, bottom right side. There is an icon here. You may please, yeah, this one, yeah, here, where your cursor is right now. Just go to the full slide mode. Yes. Here, yeah, yes, this one. Yeah, all good.
Ma'am, you are on mute.
I think Dr. Shakun, yeah. Yes.
Am I audible?
Yes.
Thank you, Dr. Sangeeta, for making part of it, and Dr. Srivastava. Anemia is the most common medical disorders which is complicating the pregnancy. And I would, at the start, I would like to thank everybody who's attending. And ma'am, really, I was really impressed by the kind of attendance you have, by the number of people who are attending. So at the outset, I would like to
Dr.
share.
Shakun, we have all over people from all over India representing various levels, right from CHO to tertiary care level. So it is going to make your task little difficult because you have to tread from the primary care level to the tertiary care level. And we have, majority are doctors, some are nurses also in the group. So maybe when you are talking, you can tailor it accordingly to their, what is it in it that they should be taking care of. Sorry.
Thanks for briefing me about it. So at the outset, I would like to share one of the cases that presented to us recently. And I would like everybody to have a basic review of what went wrong in this case. Okay, so this lady came to us in December, around 8th of December, and she had this discharge slip with her. And she was admitted on 1st October 24 and discharged on 5th October 24 at one of our hospitals of Delhi only, some peripheral hospital, which caters to central Delhi, not very far from us. And at that time, she was a primary gravida at 24 weeks around with severe anemia. And she had these investigations done that time. That time her HB was 6.3. Her MCV, mean corpuscular volume, was 116. And she had a peripheral smear also, which said there are macrocytes and hypersegmented neutrophils. This was a treatment given to her. She was transfused 1 unit of PCB. She was started Orofor XTBD. It is an iron preparation and it costs 15 tablets cost 312. A normal Fersolate costs around 1 or 2 rupees per tablet. And with that treatment investigations, her serum ferritin was also done, which was normal, and this was done prior to transfusion. Okay, and she had this discharge slip where she was given tablet Orofor XT again, vitamin C, some multinutrients, calcium, B complex, and again she was asked to review after 2 weeks. Now, what's wrong here? Definitely something went wrong. The diagnosis of type of anemia was wrong. So every anemia is not iron deficiency anemia. And then second problem was follow-up. After receiving the blood, after continuing with iron supplementation, the lady sat at home and then came when she became very sick. She came to us on 8th of December, early morning. It was a Sunday. And that time she was 33 weeks. Her BP was also high at that time, 150, 100 when she went to Kasturba Hospital, and when she reached us, her BP was 140, 90. Respiratory rate was 28 per minute. And she had severe pallor, pedal edema, abdominal wall edema, seemed to have ascites also. So in between, she never followed up. There was vulval edema also. So it's very, very important. And this is one case, and every 2 or 3 days we have these kind of cases in capital of India. And these women are residing in Delhi. And this lady was a resident of Chandni Chowk, which is hardly 5 to 6 kilometers from our place. So we are wrong somewhere. And these are all preventable complications. So let's see what do we need to do about it. So anemia in India, almost 53% women are anemic. And in pregnancy also, it is reflected, and almost 50% of women are anemic. And this adversely affect the mother as well as the baby. So the rate of anemia varies from 50 to 80% at certain places. And now earlier, even everybody, doctors and everybody was not sensitized to it. Now any HB less than 11 gram% during pregnancy it should be labeled as anemia. Now we need to see that this condition is in spite of Anemia Mukt Bharat Abhiyan, which was started in 2016. And at that time, we had wanted to make the rate of anemia as 32% by 2022. And now we are in 2025, and we still have almost 50% rates of anemia. However, the rates of severe anemia have reduced. These patients are timely referred and managed. The blood facilities have improved. The deaths are not reducing, but still anemia we are not able to reduce to that level. Anemia itself very rarely causes death. However, what it does is it increases the morbidity due to other complications like postpartum hemorrhage, preeclampsia, and also causes preterm delivery and low birth weight. So not only neonatal risk and risk to the babies because of low iron stores and B12 stores, there could be increased chances of placental abruption. And now regarding postpartum hemorrhage in a case of anemia, what happens is these women who are already anemic are at increased risk of bleeding. Moreover, they do not tolerate any kind of bleeding. Smallest amount of blood loss, they will go into shock. They are increased risk of preeclampsia. Moreover, high BP, they are at higher risk of going into CHF when both preeclampsia and anemia is there. Similarly, if a patient is anemic and she has APH or she has PPH, we will have a lower threshold of performing a hysterectomy to save the life of the lady and reduce the blood loss further. So because the allowable blood loss in these women is less during delivery, and so it continues to be an important contributory cause of maternal death. Whether it's sepsis, whether it's PPH, whether it's preeclampsia, if the patient is anemic, she has higher chances of landing up into maternal death or severe maternal morbidity if she is also anemic. So as Dr. Pawan highlighted the importance of utilization rates with antenatal care, and that's what happened in this case. She never continued to have a regular antenatal care. And we talk of 4 antenatal visits in India, but ideally there should 8 have contacts with healthcare providers have been advised by WHO. So we need to have a relook at this. So are these visits enough, or do we need more contacts? Definitely ASHA worker is there tracking and getting these women to the facility if there are any features of complications, danger signs, or in any other complication during screening. So now, why anemia in pregnancy? What happens is the plasma volume increases by almost 45%, but the red blood cells, they increase only by 30%. This causes physiological anemia. And because of this, what happens is the hemoglobin during pregnancy is lower than in adult. And how do we define anemia in pregnancy? So any hemoglobin less than 11 gram percent. I had a slide for definition. However, in first and third trimester of pregnancy, less than 11 gram percent is anemia. However, in second trimester, 10.5 is supposed to be anemia. That slide is missing. Okay. Now, and in postpartum period, less than 10 gram will be considered as anemia. Now, what about why we are so much worried about iron deficiency, and why iron deficiency is the most important cause of anemia during pregnancy? It is because of extra requirement of iron during pregnancy. And during pregnancy, 800 to 1000 milligram of iron is required, which is extra from the regular requirement. So out of this, 300 milligram is required for the fetus, 50 milligram for the placenta. Almost 400 to 500 milligram over the full pregnancies is required for increased red cell mass. About 500 milligram is lost during delivery and basal losses. There is some cessation, some gain, or some reduced loss due to cessation of menses and contraction of blood volume after delivery. So in total, about 800 to 1 gram of iron extra is required during pregnancy. But how does it pan out? Let's see. Normal diet contains about only 14 milligram of iron, of which about only 5 to 10% is absorbed. And that might be even lesser if it is a pure vegetarian source. So, additional daily iron demand in early pregnancy, which is 2 to 3 milligram, and later in pregnancy, which is 6 to 7 milligram per day, will have to be met by an additional 40 to 60 milligram of elemental iron during pregnancy. And currently the iron folate which is available in the government supply has 60 milligram of elemental iron, the phosphate which is available, and 400 there is increased requirement of folic acid also, which is about 400 to 600 microgram per day. Now there's one more problem. Apart from folic acid and iron, which is very important component, is B12, which is not covered by our even phosphate tablets. And now everybody is aware of iron requirement. So what happens is, in nutritionally deficient females, they are supplemented with iron and folic acid. So the B12 deficiency gets unmasked So these ladies land up with macrocytic anemia, and apart from that, it is anemia. These women also have neurological side effects, as well as there is thrombocytopenia. So that's what happened in our patient who presented to us. She inherently had a B12 deficiency, but she was given blood and given only iron supplementation without B12 supplementation. And she, next time when she comes, her HB is not increased, and her, in addition, she had thrombocytopenia. Dr. Sangeeta will be telling more about iron, so I will skip the pharmacokinetics of iron. So what are the risk factors? Now, which are the ladies? So our normal diet, normal physiology is prone towards anemia, and over and above, there are certain factors, risk factors, in which ladies become more susceptible to anemia. These are if there is less than 1 year since last pregnancy, anemia in previous pregnancy, age is less than 20 during pregnancy, she is twin or more pregnancy, the requirement increases. If she is parity is 3 or more, she's had previous 3 or more children, then definitely her diet is not enough, and medical condition like malabsorption, or she's losing blood because of hemorrhoids, etc. So they also increase the iron deficiency. So apart from the main important cause of iron deficiency, what are the other causes of iron deficiency? We talked of folic acid and B12 deficiency. Vitamin A is very important for epithelial maintenance. So if there's vitamin A deficiency, there will be reduced absorption, inadequate. The cooking and eating practices are very important, like not cooking in iron utensils is not very favorable. Rather, if we cook the food in iron utensils, the food becomes iron rich. And having tea immediately after food reduces the absorption. So even dairy products, if are taken immediately after iron tablet or food, the iron absorption is reduced. High or low BMI and history of bleeding, whether it be abnormal uterine bleeding, hemorrhoids, etc., that can also cause anemia in pregnancy. Vegetarian diet is low in B12, low socioeconomic status, infections, malaria, helminthic infestations, chronic disease, especially chronic kidney disease, genetic disorders, especially hemoglobinopathies. Northern India, we are in thalassemia belt, and it is very important. At present, these women with thalassemia major very rarely do reach the reproductive age group, but many of them are not fertile. But it's just matter of time, we might have these women also. But many of the women who come to us might be carriers. Now, in these carriers, we need to screen the husband also, because these women have chances of having a thalassemia major baby. So we need to have genetic testing to know whether this baby has, the fetus in utero has thalassemia, and we should be able to offer MTP if there is a baby or a fetus which has thalassemia major, because of monthly requirement of blood transfusion and morbidity associated with thalassemia major. And definitely we have acute blood loss, antepartum hemorrhage because of placenta and abruption causing anemia. So this was the slide which I was referring to earlier. First and third trimester of pregnancy, HB less than 11 gram percent as we define as anemia in second trimester 10.5 and postpartum less than, and investigation of choice is hemogram, or also called the complete blood count, which has counts of various RBCs, WBCs, platelets, but in addition also tells about the hemoglobin. Now talking about severity of anemia. How do we classify anemia as mild, moderate, severe, and very severe? So less than 7 becomes severe, and 10 or more is mild. So a very big range between 7 and 9.9. 7, 8, 9 becomes moderate. And actually every lady in moderate range is not similar. Any lady who's having 7.5 near term will require transfusion. So it is a very big range which has been given and requires a closer look. Very severe anemia, those ladies who will land up in failure, very low, very high chances of landing up in failure. CHF is less than 4 gram per deciliter. So 7 to 9.9 becomes moderate, very large, but it is not a homogeneous group, it is a heterogeneous group, as we'll see. And you must have come across all these mild, moderate, severe group of ladies with anemia in your pre-test, which you'll get in your post-test also. So what is the clinical presentation? That depends upon severity of anemia. And there's very important thing, interesting thing about anemia. The ladies confuse the symptoms of anemia with physiological features of pregnancy. So they think the symptoms which are occurring are not because pathological cause or any disease. They feel they are pregnant, that's why they are having these features of weakness, fatigue, and initially what they do is they keep on restricting their activity. So only then when they become severely anemic, they are not able to catch up with breath, and they have severe weakness, fatigue, and dyspnea, and palpitation on exertion. Do they approach? So it is the duty of the healthcare provider to screen the lady by doing hemoglobin at every visit. If it is 4 visits only, to know apart from history and examination, to rule out anemia, because the lady will come to the facility only in case of. Am I audible?
Yes, ma'am.
Okay.
Yes, ma'am, you are.
There was a
It's
message that
audible.
not audible. Okay. So what are the signs? Pallor, where all pallor need to be seen? So pallor in palpebral conjunctiva, in palate, in palmar creases, and nail beds. Pallor should be looked at every places. But in late stages, patient or lady could have facial puffiness. And when going into failure, she'll have raised JVP, tachycardia, tachypnea, creps in lung bases. If the failure is because of some other reason, then hepatosplenomegaly might be present. Pitting edema might be present because of CHF as well as hyperproteinemia. There could be abdominal wall, leg and valval edema as well. There could be deficiency features of other vitamins, and she would have glossitis, stomatitis, cheilosis, and brittle hair. The heart will show pansystolic murmur, very rarely, but usually an ejection systolic murmur will be present. So we discussed about the impact of anemia on preeclampsia, abruption, also known of preterm, but anemia also predisposes to puerperal sepsis. subinvolution of uterus, lactation failure, and maternal mortality could be due to preeclampsia, exacerbations of PPH, eclampsia, CHF. There could be cerebral anoxia, sepsis, and thromboembolism. Because although the fetus is a parasite, until unless the mother is severely anemic, the baby will not be affected. But when there is B12 deficiency or very severe iron deficiency anemia, there's higher chances of intrauterine growth restriction, IUD, low Apgar at birth, and low iron stores in the neonate in that case, and the neonate becomes more susceptible for anemia and infection. And then there is higher perinatal morbidity and mortality, and anemic infants with cognitive and affective dysfunction also. So when a lady is anemic, especially severely anemic, what are the critical periods? So 28 to 32 weeks, when the volume overload is maximum, there are very high chances of her going into failure. Then in labor, when contractions are occurring, then immediately after delivery, when the blood is pushed back into circulation, almost early puerperium, the lady has higher chances of failure. So we have to be very careful while transfusing and giving any kind of fluid to these women. So how do we work up any patient once we have diagnosed her as anemia by history, so we take a detailed history by ask her about any chronic bleeding episode, worm infestation, any episode suggestive of malaria. On examination, we look for very features of anemia we discussed earlier. Also, jaundice could be there in case of hemolytic anemia. Splenomegaly could be there in case of, suppose there is hemolysis due to hypersplenism. A bleeding disorder, she'll have purpura. Chronic diseases like tuberculosis and renal disorders, any history and examination should try and find out, and definitely features of failure. So our investigations are focused to know the severity of anemia, the type of anemia. We need to know what is the bone marrow activity and what are the causes of anemia. So for severity of anemia, hemoglobin and hematocrit should be done at every visit if it is normal, and if it is low, then it might be repeated depending upon what was the previous hemoglobin. For type of anemia, peripheral blood smear is the basic minimum and is easiest and gives maximum information without much infrastructure requirement. However, we can have now we have RBC indices available with us if peripheral blood smear cannot be done. So the picture could be microcytic, macrocytic, dimorphic, normocytic, hemolytic, or pancytopenia. Bone marrow activity can be known by reticulocyte count. Normal is 0.2 to 2%, and higher bone marrow activity is seen as a response to iron following acute blood loss, and also in case of hemolytic anemia. And further specific investigation according to history and blood picture and response need to be done in case we want to further find out the cause of non-response. So in iron deficiency anemia, the peripheral blood smear, which is very important investigation, microcytic hypochromic, and in case of B12, macrocytes and hypersegmented neutrophils. Apart from that, malarial parasites can be seen, target cells in thalassemia, abnormal blast cells, and features of hemolysis can also be known. Schistocytes can also be seen. So these are pictures This is iron deficiency anemia, and isopoikilocytosis is there. Now here, target cells can be seen, hypersegmented neutrophils for B12 deficiency, target cells for thalassemia. And this peripheral smear has shown sickling, which is precipitated in sickle cell anemia in cases when there is hypoxia and stress. So in Our Lady, she was prescribed iron when ideally she should have been given B12 because her smear showed macrocytes and hypersegmented neutrophils. So red cell indices can also be done, where we come to know about RBC count, hematocrit, mean corpuscular volume, mean corpuscular hemoglobin, and mean corpuscular hemoglobin concentration. In case of iron deficiency anemia, RBC count reduces to below 3.2 million per cubic millimeter, and hematocrit is less than 32. Mean corpuscular volume is less than 80. In our case, it was more than 100, representing macrocytic anemia and B12 deficiency. And there is reduction in mean corpuscular hemoglobin and mean corpuscular hemoglobin concentration in case of severe anemia and anemia rather. So what about stores? So serum ferritin is mainly for knowing the iron stores, and if it is less than 20 or 30 variously coated nanogram per ml, then it suggests iron deficiency anemia as a cause. And serum ferritin is the first to fall in case of iron deficiency anemia. However, when there is, in addition, infection or inflammation, then serum ferritin is not a very good criteria. In that case, we look at other factors such as serum iron binding capacity, and percentage saturation of transferrin, because inflammation and infection increase the serum ferritin values. So, why we want to know the difference between iron deficiency anemia and thalassemia? Because both are associated with microcytic hypochromic anemia. So what is the main difference? First is RBC count, and because of that, Menzel's index is less than 13 in thalassemia and more than 13 in case of iron deficiency anemia. And what is Menzel's index? It is mean corpuscular volume divided by RBC count. Okay, so because RBC count is low in iron deficiency anemia, the Menzel's index is more than 13. However, in thalassemia, the mean corpuscular volume is low. However, the RBC count continues to be high. So therefore, the Menzel's index will be less than 13 in case of thalassemia. So other specific investigation will depend upon the response to iron, by history, examination, and result of other investigation. Like, suppose we are suspecting chronic renal disease, okay, then urine examination for RBCs and CAS can be done. If we are suspecting worms, stool for examination for, or any chronic bleeding from GI tract, then stool for ovasitral blood can be done. Refractory anemia, or when we are suspecting aplastic anemia, really bone marrow examination might be required. And similarly, X-ray test and requirement for KFTs. So how do we manage? The 4-pronged strategy includes improvement in diet and treat the lady and supplement her. and we can also do food supplementation. Now, talking about iron, there could be various sources of iron in food. So there could be heme and non-heme sources. Heme sources include meat, poultry, seafood, chicken liver, egg, shrimp, salmon, canned sardines. But in our country, vast majority of population is vegetarian. So we can suggest grain, nuts, beans, spinach, lentils. Jaggery, very good. Source, soya black-eyed beans, potatoes with skin. So they could be good source. So lentils, beans, and our gur chana. We've been always told that gur chana, and when along with food, if lemon, orange, guava, or amla, or green mango are taken, it enhances the absorption. So that is very important. And avoid taking tea and coffee and milk, which reduce the absorption. So, talking about iron supplementation in pregnancy. So, initially 60 milligram elemental iron tablets were available, but in between for certain years, 100 milligram elemental iron tablets were also available with 400 micro folic acid daily. However, because of increased GI intolerance and reduced compliance, again we have switched over to 60 milligram elemental iron tablets along with 400 microgram of folic acid. And in therapeutic doses, it can go to, dose can go to 120 to 200 milligram per day, which is easily absorbed till the side effects appear. So the tablet can be given twice or thrice as a therapeutic dose. So what should be the route of administration? It will depend upon severity of anemia, the gestation age at which anemia is diagnosed, compliance, tolerability, and also one more very important, added comorbidities. If suppose she is a case of heart disease or hypertension or preeclampsia or any other comorbidities are also present, then the route of administration will differ. Various preparations, I think Dr. Sangeeta will be talking more about about it. Various fumates. Earlier we only had fumarate, gluconate, succinate. Now we have sulfate and ascorbate, but with various GI side effects like nausea, vomiting, gastritis, diarrhea, and constipation. And Dr. Sangeeta will be dealing more about iron treatment of anemia in pregnancy and non-pregnant state as a whole remains similar. Not iron is usually not given in first trimester because of GI intolerance mainly, but also can cause higher risk of miscarriage, birth defects, and once the lady starts taking iron, the first indicator of response is feeling of well-being and better appetite, followed by increased in reticulocytes by 7th to 10th day, and hemoglobin rises about 0.5 to 0.7 gram per deciliter per week after 2 to 3 weeks by oral. Theoretically, it is said that oral and injectable therapy has similar rise. However, practically it has been reported that better rise is observed with injectable. Therefore, contraindication to oral therapy is intolerance to iron, severe anemia, after 36 weeks, and non-compliance, and failure to respond to oral therapy, which could be because of inaccurate diagnosis, as we saw in our case. It could be faulty absorption due to taking additional tea or something, or it could be because of celiac disease or malabsorption syndrome, continuous blood loss, coexistent infections, or concomitant folate and B12 deficiency. So, when are parenteral iron transfusions indicated? First of all, intolerance to iron, impaired absorption of iron, and poor adherence to oral iron therapy. Mainly currently iron sucrose and ferrous carboxymaltose is used. A very nice formula to calculate the dose, weight in kgs into deficit into 2.2, and we add 1000 for iron stored. The response comes early, and adverse effects include allergic reaction, which is very, very rare. We have reported a reaction with iron sucrose when it was given very rapidly, and rhabdomyolysis can occur rarely. So, apart from that, treatment of underlying conditions, especially deworming, treatment of malaria, especially in endemic cases, and iron supplementation, very, very important factor in these women. Delayed clamping of umbilical cord at delivery will help in giving good stores to the baby, and B12 and folate deficiency should also be catered to. How do we manage if there is B12 folic acid deficiency? So normal RDA is 400 microgram for folic acid, and 1 milligram per day if there is a lady has had history of neural tube defect, or if she takes drugs which reduce folic acid absorption, especially antiepileptics. And if she has had metformin earlier, and 4 milligram per day if the woman is taking antiepileptics and sickle cell anemia. With vitamin B12, the oral requirement is 1500 microgram per day for treatment for 1 week, and because it is a water soluble, if it is taken orally, the lady will have to continue to take 1000 to 1500 microgram per day. Then for if it is given intramuscularly, 1000 microgram daily for 1 week, followed by alternate day weekly, and then monthly 1000 microgram will have to be administered. What are the indications for blood transfusion? So severe anemia first seen after 36 weeks of pregnancy, near term. If the lady is there, the lady does not have time for anemia to be corrected by her physiologically, only by supplementation. She will require blood transfusion. If the anemia is due to acute blood loss, like APH or PPH, if there is associated infection, because that suppresses the bone marrow. If the patient is not responding to oral or parenteral therapy, if it is due to, suppose, there is no iron deficiency and there is chronic renal disease, in that case, erythropoietin will have to be added. If the lady is severely anemic and we are giving blood, it is very, very important not to overload. So injection furosemide 20 milligrams slow IV must be given before starting the transfusion. and the transfusion needs to be monitored very closely in such cases. Management of labor in anemic patient, she has to be supervised very closely, proper counseling. Apart from routine management of labor regarding hydration, nutrition, ambulation, blood needs to be cross-matched for her. She needs to be nursed in a propped up position because she can go into CHF anytime. Intermittent oxygen will need to be administered as per requirement. Aseptic precautions must be taken to prevent infections and blood loss. Minimize per vaginal examination. Prophylactic antibiotic is controversial. If good asepsis is maintained, prophylactic antibiotics will not be required. Patent IV line must be there, but fluids must be avoided. And diuretics in form of furosemide will have to be given if the lady decompensates. In second stage, it has to be cut short by an instrumental delivery. Active management of third stage of labor will have to be done by giving injection oxytocin 10 units IM, anterolateral aspect of thigh, delayed umbilical cord clamping, and looking for uterine contraction, and delivery of placenta by modified Barnard-Bruce method. In peripheral areas, per rectal misoprostol can be given after delivery of the fetus, 800 microgram. Injection methogen must not be given. Methyl ergometrin is contraindicated in cases of anemia as prophylaxis. However, it can be given as therapy in mild to moderate anemia. We have to be very, very cautious. Even normal blood loss may not be tolerated by this woman, and she might become hypoxic, and normal blood loss can cause abnormality in vitals and precipitate features of postpartum hemorrhage. If it is suspected that there is cardiac overload, because all the blood that was inside the uterus is pushed into the circulation, IV furosemide slow 20 milligram must be given. Very close monitoring is required in postpartum period. Should monitor her respiratory rate, pulse rate, oxygen saturation, blood pressure, chest basis, bleeding PV every 15 minutes for first 2 hours, and then half hourly for few hours before we can be assured. Early ambulation is encouraged because women with anemia have higher chances of thromboembolism. Hematinics should be continued till the lady breastfeed, until unless we have given her injectable FCM, which takes care of her stores also. We need to take care of her subinvolution, puerperal sepsis, CHF, thromboembolism, and lactation failure. She should avoid pregnancy for 2 to 3 years. Barrier contraceptives and progesterone, Chaya, can be given immediately. POP after 3 weeks. Post-placental IUCD should not be given if HB is less than 10. So if it is corrected, if anemia is, we are able to correct it, then we can give it. Then post-placental IUCD is also contraindicated if she's had PPH, if there is premature rupture of membrane for more than 18 hours, if she's had prolonged labor, and if there is distorted uterine cavity, or because of fibroid or any congenital malformations. So we must ensure that the lady does not have a very frequent pregnancy by giving a good basket of postpartum contraception. So Our strategies continue to be early iron deficiency treatment before or during early pregnancy, that is, after first trimester, improving quality of antenatal care and communication, engage the family and male partners in healthcare decisions, and developing targeted health policies for vulnerable population. So prevention is better than cure. Better have beans, greens, and take pills and vitamins than go for IV iron transfusion or blood transfusion. So I would like to conclude that taking care, we need to tell our women that taking care of themselves is the first step of taking care of their babies, and for us also, all healthcare providers. We can take care of our family and patients only if we take care of ourselves. Thank you.
Thank you so much, ma'am.
Thank you, Dr. Shakun, for taking us through the, from prevention to management. I think prevention is the best cure we must focus on, but somehow, the practice of medicine has been such that we focus more on the treatment, not on the prevention part. But prevention is the best approach, the most effective and economical approach. I think you'll be available. I'll not take much time, talking about the pharmacotherapy. Then we can take the questions.
Sure.
Yeah, you'll be around, no? Okay. I'll quickly take you through the, pharmacotherapy. Where is my... Aman, I don't need introduction. I think most of them are, repeat returning participants, so most of them know me. Anyway, I am a professor of pharmacology working at IBHAS and also president of DSPRUD. Let's quickly go through the important challenges with the pharmacotherapy. This is the today only I read this news article. This is the study conducted by Department of Biotechnology. And they reported the incidence of anemia. It was around 35% and and most of them, but the concerning part was that 22% of them were characterized as anemia from unknown causes. So we don't know what is this. And if you compare this with the NFHS, prevalence rates, it is NFHS said that the adolescents had more anemia compared, although it has declined, but they had more incidence of anemia as compared to the adult women. So we know that this is this is the magnitude of the problem that we have. Now, but question before us is, are all iron preparation equivalent? Can you use them interchangeably? If one preparation is not available, can you replace it with the other one? And then the second important question is, how do we evaluate these iron preparations? Most of the time when we are talking about is, we talk about elemental iron. What is this elemental iron, and how do you compare this while selecting these? Now, various preparations of these oral iron preparations are available. Dr. Shakun also talked about it. Most common and the most, widely used, and I think for ages we have been using this ferrous sulfate, then we have ferrous gluconate, fumarate, polymaltose complex, and then heme iron polypeptide, carbonyl iron, and like that. Now several new preparations are also available. But one thing I wanted to point out here is, look at the elemental iron content in these preparations. This is variable according to different salts that we have. Ferrous sulfate has around 20%, gluconate is 12%, whereas fumarate is 33%. Polymaltose complex varies, different preparation, but around 30% is there. So carbonyl iron is 100%. Elemental iron is the pure iron that is available for action. So we need to look at this. But then one thing comes to our mind is more elemental iron, the more efficacious it is or not. So if you look at it need not, although the elemental iron is important, how much iron will be, because if you have a 325 milligram tablet, but it will have only 65 milligram of elemental iron. Most of the time errors happen, particularly when you are treating a child, when you are using different, iron hematinic preparations. We think that these are interchangeable, but the elemental iron content may be very much different, and we may sometime overdose the patient because we thought that it was interchangeable. So look at the elemental iron and then look at whether it is highly efficacious or not. And most of these are used for iron deficiency anemia, and have fumarate is also high efficacy. Then polymaltose is effective. Heme iron is effective absorption, especially it is beneficial in individuals with certain type of anemia. Tolerability, then the second part when you are deciding about the iron preparation, which iron preparation to be used, is the tolerability profile. Whether, because the most common side effects are the gastrointestinal side effects, which are disturbing, and the patient, the compliance, Dr. Shakun was talking about the compliance part. If the patient is not adherent, very often non-compliance is because of these side effects, because the patient finds it disturbing. Either it can cause diarrhea or constipation, and even, dark stools, because this is containing iron. So it may color the stools. Some people get frightened to see the dark color stool, black color stool. They think that, something has happened to them. So in fact, you can use this as a surrogate marker for monitoring compliance to the medication. Sometimes, the patient may come and tell you that, I have been taking this medicine, but you don't see any rise in hemoglobin. The cause may be that non-adherence, but patient is not coming up with this. So if the moment you inquire about the color of the stool, then you'll know that the patient has been taking these medicines. So all these oral preparations that we have, there is a difference in the side effect profile, more so about the gastrointestinal upset. This gluconate and the fumarate, they are better tolerated than sulfate, but individual differences could be there. Why is it moving? Yeah, this is not all brands are formulations are equivalent. There may be a difference in the component. Please look at this and prescribe the dose of these iron preparation, while calculating the elemental iron, content of that preparation. 1 milligram is not, iron is not equivalent to 1 milligram elemental iron. So please remember that when you are calculating the dose. Okay. So as I said, while prescribing, look at the elemental iron content, and then high elemental iron does not always mean better absorption, but can affect the dosing frequency. So it can be lesser with higher content elemental iron. Then all are effective, but individual responses vary, mainly, as I said, because of the underlying cause of the deficiency or some patient-specific factors. If the patient is having malabsorption, other illnesses which are affecting absorption, then it can affect the absorption of these medicines. So additional, you can consider, you can prescribe absorption enhancers. Vitamin C is a very good enhancer of iron absorption, and this can be recommended alongside of supplementation. Timing, iron supplements are best absorbed empty stomach, but then they can give rise to more side effect. And giving after food, with food or after food, side effects may be less, but then absorption would be affected. The fiber in the diet may interfere with the absorption. So that is the best time for giving iron supplement. That is why is in between the meals. Now, in between the meals, then we may be the patient may be consuming other things in the diet or taking other supplements. I'll be talking about this, because then you need to space out the timings of iron, because iron has a lot of interaction with other supplements that we give or other drugs that the patient may be taking for other indications, and the diet food drug interactions are also quite common with iron preparation. So most of the time when you see non-response to iron, oral iron, in iron deficiency anemia, if the diagnosis was correct, most of the time the non-response is because of this interactions, because the timings are not right, and the iron is not best absorbed from the gut here. So additional is that you look at, as the Dr. Shakun was also saying, if the patient is having other concomitant morbidities like gastrointestinal conditions, IBD, celiac disease, chronic kidney disease, dialysis patients, they, and those with a history of iron overload. Please don't forget belts where the sickle cell anemia is very common. Those are already receiving these iron preparations, so iron overload may happen in these patients. So consider this while you are prescribing these preparations. Now there are several. Most of the time there is a question whether you should be giving oral or parenteral iron preparation, and amongst the parenteral iron preparation, there are several preparations that are available in the market. Now, which one is more effective? And for quite some time, we were using iron dextran. Again, if you look at the elemental iron content, it varies according to the different parenteral iron preparations. Iron dextran was being used. Efficacy was good. Tolerability was moderate because anaphylaxis was a major problem. Although it was rare, but whenever these anaphylaxis happened, these were serious. So this required a lot of monitoring while giving iron dextran, and the cost, although it was a cost effective, but now iron sucrose is being majorly being used. It is highly effective, especially in patients with CKD. It is well tolerated. Again, hypersensitivity can happen, but it is rare, but we need to be looking for it. It can cause hypertension, nausea, and dizziness. Cost is, I think, low again, so this can be afforded. It is cost effective, but ferric carboxyma is high, cost is very high. The symptoms are, side effect are less. It is highly tolerable. Lower allergic reactions are there, but then you have to weigh because the cost is very high with this ferric carboxymaltose. Then there are other preparations, low molecular weight iron dextran, hepcidin analog. These are emerging therapies. Iron isomaltoside, these are there. This is also being used, but cost is again high. So you have to look at the elemental iron content, and then total dose calculation is done. I think Dr. Shakun said I had this 500 milligram for the stores, but you said 1000 milligram. So you can use that formula to build these stores of iron. Then these preparations, they may vary according to the we must know the administration regimen. how much elemental iron to be administered, and how these regimens are. Some are given as single infusion, some can be divided, some can have to be given. Iron sucrose has to be given 2-3 times per week. So that may also decide about the convenience, the adherence to this. Ferric carboxymaltose, single infusion, you can give. Iron dextran is single dose, but slow. Like that, you have to see, you can make this table, and or the most effective parenteral preparation that you would like to use, you can have that dose ready on your table with this. Now the biggest question is, when do you choose? There are certain indications, definitely, for going for iron, parenteral iron, when we want patient is intolerant, cannot take orally, or you want to build the hemoglobin rise quickly. But the timeline, what is the comparative timeline? Many of the us have a belief that the parenteral one leads to rapid rise in hemoglobin. Initial rise may be more rapid with the parenteral iron. But if there are studies which have shown, if you look at the at 12 weeks, the rise of hemoglobin is same with iron preparation and parenteral. Now, why are we? Just a minute. मैं अभी क्लास ले रही हूँ, मैं बाद में बात करूंगी, दादी से बात कर लो. Because many times, although when indicated, you must use parenteral iron, but this is not a replacement for oral. In one of the state I visited, some time back, and there I found that everyone was being given parenteral iron, all on the pretext that quality was bad. And then I was very much worried, how is it that no one is on oral iron and everybody is receiving parenteral iron? And at that time, iron dextran was being used. So, and it had some anaphylactic reactions, and which could be fatal if it happened. So then I realized, when we were talking, first was the misbelief that the parenteral iron is the fastest one, and that is why they want to use. Second is that because they did not find any rise in rate of hemoglobin, which when I investigated further, it was because of the interactions with the calcium supplements that was inhibiting the absorption of iron. And they misattributed this to the bad quality iron preparations. So please keep this in mind, whenever you are choosing oral or parenteral iron. But initial rise may be more faster, rapid with the parenteral one, but ultimately the rate of rise of hemoglobin is same in oral and parenteral. And again, one more thing, many times when we start these, supplements, iron preparations, and then we start testing next week, this rate of rise will be visible only after 2 to 3 weeks, maybe 1 month. In about 4 weeks, 1 gram hemoglobin may rise. So keep those things realistic targets in your mind while you are doing the follow-up and evaluating these patients. Because then, because if we expect an early rise, then we may think that these oral iron preparations are not working. Intramuscular therapy is not recommended due to risk of unpredictable absorption, anaphylaxis, and local complications. It can lead to permanent staining of the skin and sarcoma form. So only IV preparations are given. Now, what are the scenarios which favor parenteral iron for faster hemoglobin rise? Dr. Shakun has already said, when you have the patient has severe iron deficiency where rapid correction is required, where the patient is symptomatic and have cardiac strain, then you may require this. Pre-operative optimization, you have a patient with severe anemia and has to be taken for surgery, LSCS, then you may need this. Pregnancy with severe IDA or those who cannot tolerate, we have already said cancer patients with chronic inflammatory conditions and malabsorption syndrome are the patients who may require this. So consider some caveats for parenteral iron. So while it is available, it has changed, led to the faster rise, effective treatment for these patients. But remember the risk of ADRs, cost and accessibilities. This IV preparations would require monitoring. Need for healthcare supervision, patient preferences and compliances. Some patients may still prefer oral preparation vis-a-vis parenteral preparation. And these parenteral iron preparation, they will definitely treat the anemia, but it does not resolve the ongoing sources of iron loss or malabsorption. So even that is true even with iron, oral iron preparation. You must look for the underlying cause of anemia, because this will just replenish the iron stores and treat the anemia for the time being. But if you do not know the source of anemia, this will keep continuing. So I think I've already said this. Now, coming to the drug-drug interactions, there are, think of the common drugs which can be needed during pregnancy for the treatment of anemia besides iron. Antibiotics may be required if the patient is having. Tetracycline and fluoroquinolones are the ones which will decrease the absorption. So avoid these drugs. Anyway, fluoroquinolones are contraindicated, but if no alternative is available, but keep this in mind, give the timing is 2 hours apart. Iron and the tetracycline should be given 2 hours apart to avoid this. Now, some patients may be hypothyroid. They may be taking levothyroxine. Again, it reduces the absorption. Levothyroxine is given empty stomach. But then again, iron supplements should be given 4 hours apart. Remember these are the common drug interactions that you may see these patients. Now, many of the women in pregnancy may be having gastritis. So you may be prescribing antacids or proton pump inhibitors. Again, they reduce the absorption of iron. So because these antacids contain calcium, magnesium, aluminium, so these chelate with the iron. So this is a very common interaction. Iron, calcium, magnesium, they chelate with each other. Chelation means they bind to each other. So binding to each other means none of these will be absorbed. Neither iron will be absorbed nor calcium will be absorbed. So again, it comes back to timing of these patients. If you have to give antacids, you have to give because the patient is having symptoms. You have to relieve her of these symptoms. But then timing to minimize the interaction is either take the iron supplements at least 2 hours before or after these medications. Many times people say, one will be given in the morning, one will be given in the evening, or give one at a time. These are not feasible because during ANC visits, you have to give both calcium and iron together. So you can't say, I will give only iron or I will give only calcium. Similarly, even if you give morning, evening, separate them, but then there are food drug interactions that may take place. I'll be coming to that. So generally remember this, to take iron supplements at least 2 hours before or after these medications. Okay, so this is same for magnesium, calcium supplements. Then the patient may be taking some other iron containing supplements. This can lead to potential iron overload. Many times it happens, patient is taking some herbal medicine or Ayurvedic medicine, which may also be containing iron. So please must know what all supplements the patient is taking. They may not be forthcoming to you and telling these things that they are taking, because for them it is a normal part of their diet. So then look at the, because there could be risk of iron overload if you don't consider this. Then multivitamins is another, for megaloblastic anemia, you have to give vitamin B12 and other vitamins. So again, these can reduce the absorption of these, and particularly if they have these vitamins have zinc and copper in their preparation. So same kind of chelation interaction may happen. So choose prenatal vitamins formulated to account for iron interactions. Or because if they are there in the same preparation, none of these will be absorbed. So this will go waste. Then, yes, dietary food, very important. Vitamin C rich foods, they enhance iron absorption. So you can pair iron, intake with the diet rich in vitamin C. So this will help in maximizing the absorption. Dairy-rich food, dairy products, because they have calcium in them. Even tea, as Madam was saying, the patient was taking it with tea. Tea has some milk, and so calcium is there. So it can reduce the iron absorption. So that is why we say iron should be separate 2 hours before or 1 hour after taking calcium or dairy containing diet. Tea, this will include tea, dahi, even ice cream. Sometimes we don't think on those lines, but it is again a dairy product. So these needs to be spaced out. So tea and coffee, as I said, then whole grains, legumes, spinach. This spinach can inhibit iron absorption. So better to pair these, although diversification has to be done in the diet. Patient, you need not stop any particular kind of diet for this patient. The diet should be diversified, but then we can maximize this, knowing these things, interactions, we can maximize by pairing the right kind of food. So spinach and vitamin C sources can be paired quite good. High fiber diet, as I said, will inhibit the absorption. It has a variable impact. So that is why extremely high fiber diet is avoided. Moderate fiber is required, but extremely high fiber diets are avoided around the time of iron supplementation. Then eggs, red meat, fortified foods, most of them are inhibiting iron preparation. So space out their nuts, seeds, soy products. So remember, most common is dairy products, tea, coffee, and these medications. And remember that, if you were to give iron alone, there was no problem. But most of the time in ANC clinic, you have to give both, or maybe more additional drugs are required. So remember, whenever you are adding any other drug to the regimen, there is a chance that there could be a drug interaction. Now, it is very difficult to remember all the drug interactions which can happen. I usually refer to this websites. These are quite comprehensive websites where you can enter the name of the drug, and they will tell you the interaction, whether this is a major interaction requiring change in therapy or a minor interaction. So I think in this era, when everybody is carrying Android phone and Wi-Fi and internet is available to everyone, we can refer to these anytime and get benefits. So special consideration during pregnancy is that there is an enhanced iron need. This you can meet through diet, oral supplements, or parenteral as required. Medication safety, you have to look into it, which drugs can be given during pregnancy, whether they have any harmful effect on the fetus or not. So accordingly, you select the iron supplements. Then remember, nutrient interactions can take place. So you have to look at the timings of this, then because prenatal particularly look at if patient is taking any other multivitamins or preparations which can interact with iron, and of course regular monitoring is required. You look at the hemoglobin, ferritin, and other relevant blood parameters to adjust iron therapy as needed. In the case discussion, Dr. Shakun, she showed you because the patient did not come for 2 months and landed in a severe, decompensated stage, so which was undesirable and was easily avoidable. So because monitoring was missing, patient was not adhering, so we have to communicate to the patient carefully about the monitoring, regular visits, and during their visits monitor for these ADRs. Now I think there was, you can refer to the guidelines, ANC guidelines are there, then the anemia treatment guidelines are there. You can refer to these and maximize the effect or the outcomes, improved outcomes for your patient. Now, one thing that I saw in the chat box was, 4 ANC visits are the minimum visits. But many a times we take this as this is the 4 are enough. These are the minimum ANC visits. We should try and have at least 8 ANC visit as far as possible. 4 is just the minimum, and especially for the high risk pregnancy, anyway 4 plus 3 are advocated. So you must ensure that this 7 ANC visits take place, where you can screen for these hemoglobin, and then look for the cause of this iron deficiency or anemia. Most of the time it is iron deficiency only, so that is why we many a times take anemia as equivalent to iron deficiency anemia. Remember, anemia can be caused by other nutrient deficiencies, iron deficiency anemia being the most common, so that is why we are discussing the iron deficiency anemia here. I think that's all for today. Next session is on fever of unknown origin. That's on 15th February. See you on 15th February. If there are any questions, we can take this.
Thank you so much, ma'am. I think, ma'am, many participants have posted questions in the chat box.
Okay, let's see.
And we have also posted the link to the post test in the chat box. Participants are requested to please go through that as well.
Dr. Shakun, can we start taking the questions? Yes, she's there. Yeah. Okay. There is a question in the chat box. As plasma volume increases 45%, how much is circulating blood volume in normal pregnancy?
So there are almost 30 to 50% rise during pregnancy. So in non-pregnant, the blood volume is around 4.5 liters. So it becomes almost 5.5 to 6 liters during pregnancy.
Okay, then there is a question on daily dose versus alternate dose. Day dose of iron gives the same result. Your take on this?
The problem is alternate dose will require higher dosage, and which will increase the gastric intolerance. That is a problem. The more the dose, more GI irritability will be there, more chances of reduced compliance.
Okay. Same is true with higher elemental iron. It reduces the frequency of tablets, but the chances of side effect would be more with the higher dose. So you have to balance individual patient-specific factors. Tolerance needs to be taken into account.
If the patient is able to tolerate, then you can give it.
Yeah. Then vitamin C, chewable or tablet, which is better?
It has to go into the stomach.
I think more than that, chewable or plain tablet you have to take with water. You have to think of the interactions with other food items. Timings are more important. Timing.
When you chew or suck vitamin C, it is not absorbed from the mucosa. It goes into stomach and there it is absorbed. It is as compared to other chewable or sublingual misoprostol or sorbitrate and all. So it has to go into stomach. I don't think it should matter whether you chew it
It
or
is,
you.
I think only some people find chewing as better. The same thing is true, gel, antacid gel or chewable antacid tablets.
Exactly.
Some people find the taste of gel, not acceptable to them. So they like chewing. It all depends on the patient's convenience and the preferences. From pharmacology point of view, kinetics point of view, there's no difference. Okay, please, then. Amla enhances iron absorption. Yes, vitamin C, as I said, this enhances iron absorption. So you should pair diet or iron preparations with vitamin C. So this will absorption would be more. As in one video, I don't know which, but generally our science, this thing says vitamin C is a absorption enhancer. Can iron be taken at bedtime? Again, it is the convenience, and if you are able to space out with the calcium and other dairy products, as stated, 2 hours before or 1 hour after, it is any time is good enough, depends on the patient, but you need to space out. Emphasis should be more on the spacing out or the timing of these supplements. Iron and calcium tablets be together or not? I think I've answered that. Oh, this is for you, Dr. Shakun. 6.5 gram hemoglobin at any gestation, blood transfusion is advised.
According to books, but but it can be individualized. According to books, theoretically, yes. But suppose she comes at 18, 20 weeks, her pulse is normal, she's absolutely asymptomatic, then you have to discuss, and rarely you can individualize. If suppose she's not taken oral iron and she takes, we have had patients who've come at very low HB 6.5 and they've responded very nicely to oral iron also. So, but that has to be done under very close supervision. Patient should not get lost.
Yeah, I think we had one question, but I don't remember we mentioned.
But theoretically,
6.5.
it is an indication for blood transfusion.
But I don't think so. Did we mention, do you remember in the questionnaire, 6.5 grams, because they say pre-test says parenteral iron for this patient. I don't know. We will see the question again, but I don't think so. It should be 6.5 gram, maybe more, 8 or something. Can you, Dr. Shakun, emphasize on the trimester and the hemoglobin level? I think that's where most of the time the difficulty comes in. Although we have this mild, moderate, severe classification, but the timing of the gestation.
So currently, the concepts are changing. Earlier, we used to think in general as a PG, as a resident, less than 7 is not anemia. The patients don't have any symptoms, and we never used to be very cautious. But now, teaching and practice both have changed. So, less than 8 gram%, and more than 32 weeks, near 36 weeks type, more than 36 weeks, less than 8, we are transfusing.
At any time in the
Less than 8, more than 36 weeks. More than 36 weeks, less than 8, she will require blood transfusion. Okay. Until unless you talk to them, you admit them, given them parenteral. We do this, but theoretically, you cannot teach that. So theoretically, according to books, if you go by the books, less than 8 gram and 36 weeks, she requires transfusion because she can go into labor anytime. Okay. But the other thing is, Giving blood transfusion itself might precipitate labor.
Okay.
So that is it. And then 32 to 36 weeks is a good time for parenteral iron for severe anemia also.
So again, this is individualized. Term is one of the criteria. Which term trimester is the patient in? and the
37
degree?
weeks now, she can go into labor, she can deliver, she can land up in cesarean anytime. So if we give blood immediately when she's going to go for cesarean, the blood carrying capacity, the oxygen carrying capacity of that blood is not good enough because of low 2,3 dpg, because that is stored blood. It takes around 48 hours. So if the patient lands up for cesarean section, then her oxygen carrying capacity should be good. Otherwise, her morbidity will be high. Post-op morbidity will be high. Cesarean is difficult with anemia. Now, the other thing happens is whether before that, it depends upon comorbidities and how the patient is tolerating. If patient is totally asymptomatic, her vitals are also okay. Pulse is 70. Her respiratory rate is 14. Patient is asymptomatic. There might be, and she might be 8 gram. You can easily build her up.
Dr.
But
Shakun,
she might have preeclampsia. She might be having heart disease. She might be having, she might be a previous cesarean. In that case, her chances of landing up for, if she requires induction of labor for any kind, then her minimum 10, ideally. 9 to 10, it should be there. Because then she has very high chances of landing up in. So, comorbidities, obstetric or medical,
are also important. You have
very,
to
very
consider
important
this,
in pregnancy.
take
Not
these
only
decisions accordingly.
because then if she requires surgery, if she requires anesthesia, then her morbidity will be higher if we do not transfuse her.
You know, I mean, let me ask you, today's the occasion. In one, I went for some assessment, and went to the, was looking into LSCS. The anesthesia people, I was talking to the anesthesia people. They were, making this severe anemia patient as unfit for anesthesia.
Actually,
अब उन्होंने तो anesthesia में unfit बोल दिया. This patient has come for an emergency LSCS. My question to him was, even if you say this patient is unfit, can you hold on to LSCS? You have to, delivery is imminent, you have to, for fetal distress or something, you have to do the delivery. What is the point of saying that this patient is unfit? Rather, you should work on the criteria. How do you work on this patient?
actually, they usually don't say unfit, they give ASA category. American Society for Anesthetists, they divide the patients depending upon various risk factors as ASA grade 1, 2, 3, 4, depending upon what is the risk category. And however be the high risk, when the surgery is for maternal indication, now there the difference comes. If it is for fetal distress, then we'll have to counsel the patient and the relatives, like, look, if we do it for the baby, the mother's life is in danger. You will have to give consent that the mother's life will be in danger if we do this cesarean and then let them decide. We don't decide for section in such case. When it is for maternal risk, suppose she's going to have rupture uterus, or she is having scar dehiscence, or if she's in obstructed labor, if she's having abruptio, if she's going to die if section is not, then the anesthetist will have to do whatever it is. If she's full stomach, if she's anemic, if she's anything, if she's bleeding inside or outside something, whatever be the status, how much. Recently we had a rupture uterus in labor room. We started the cesarean, and the anesthetist started inotropes. Patient was pulseless, BP less. So that There was no husband. We proceeded with hysterectomy also, with no relative and no consent also, because we had to save the patient. Patient survived. So that is what ultimately the patient's life and everything which has to be done has to be. We don't take decisions. We tell the pros and cons to the patient and relatives. Let them decide, documented. Okay, look, this is the most of the decisions in OBGY fall in gray zones. They're very white or black. There are very few decisions which are white and black. Rest are in gray zones. Here you have to tell the pros and cons to the patient, to the relatives, and discuss and document the discussion and take the signatures. That is
Yeah, documentation is very important.
very, very important. And
because
everyday documentation and signature of the relative regarding progress of the patient.
yeah, because many a times we do everything to save the patient, but we fall short on documentation. And I consider all patients as potential litigants.
Definitely.
All patients are potential litigants, and the litigation will arise only later. It will not arise immediately. So if it happens in future, the only thing that safeguards you is the documentation. If you have documented, time, you have documented the date, time, the action taken, and even the consents, refusal of consent is equally important. Refusal is equally important, because consent we do document, but refusal many times we don't document. So that's equally, मैंने आपसे ये सवाल इसीलिए पूछा because I was very much surprised. The anesthesia was working as a separate team and the obstetricians were in the different team, and he was doing his job, they were doing their job of saving the mother and the child. And he was writing unfit. I said, this is a teamwork. You have to sit together and work, because if you are getting more of the emergency LSCS to your facility, you better work out a workable criteria for making these patients fit for anesthesia or not anesthesia. So this is very important. Working as a team is very, very important. Okay. Then next question is, in preconceived period with iron deficiency anemia, whether to start iron and folic acid supplements or only dietary intake of green leafy vegetables?
So preconceptionally, if the patient has not conceived as yet, definitely anemia must be treated. Find out the cause and treat it, and then she conceives. But first trimester, what happens is, if she conceives, then first trimester the lady is not able to have her normal food. There's so much of nausea, vomiting. She will not accept any kind of chemicals. Hardly folic acid is if she is able to take. So, and otherwise first trimester we do not give. This is not anemia of pregnancy. This is anemia of some underlying cause. We need to investigate her. And then if it is because of iron deficiency, then that must be supplemented after 12 weeks.
I think I answered this question. Is multiple micronutrients with iron advisable in pregnancy? That depends. Iron and calcium are the important ones. Others will depend on the patient's underlying cause, and you have to replace. Again, look at the timings for administering this. Next question is about...
Actually, a good diet is best replacement plus iron.
Yeah.
And calcium.
Good diet में भी Dr. Shakun, what we do is हम पालक साग खाते हैं, खाते तो बहुत हूँ, पर I take it with curd. Many a times we don't realize that none of this will be absorbed. Curd is rich in calcium, that is rich in iron. So हम आपस में भी ये गलतियां करते हैं, तो what to talk about the patient?
But I think milk has milk is more problematic than curd.
Even tea, आप tea में कितना
Tea
कम
is
milk डालते हो?
definitely not, but I don't think curd is so bad.
I don't know. Just let's look at, it still has, dairy products. That is why it
Yeah,
is.
dairy as well.
It is easy to remember dairy products. You need to space out. And I told you interactions with vitamin, other zinc, like that. So you need to look into that. Blood transfusion to start at any stage of pregnancy or at term only if hemoglobin is less than 8. I think you have answered this.
So it has to be individualized according to symptoms. Patient, not reports. We are not treating the reports, we are treating the patient. What is a symptom? What is examination finding? And then severe anemia, definitely. But it always can be individualized.
Which schedule is advisable in case of anemia? 60 milligram BD or 120 milligram OD? Considering
BD would
the
be
absorption.
better. 60, 120 OD, patient will not tolerate. Too much GI side effects, she will stop taking any iron.
I know it is a lot of concern because वो spacing करनी है तो सारा दिन देखती रहेगी कि क्या खाना है क्या नहीं खाना है कब खाना है but OD में major issue is GI tolerance. You have to weigh this, again this. Then at term, if I think the question is not clear. At term, if hemoglobin is less than 8, ये भी आंसर कर ही दिया है.
क्वेश्चन क्या है?
पूरा नहीं लिखा है.
दिख नहीं रहा होगा मेरे ख्याल से.
नहीं वो आई थिंक वो कुछ कंटिन्यूएशन में था. और एक क्वेश्चन है, आर आयरन सप्लीमेंट्स कॉन्ट्राइंडिकेटेड ड्यूरिंग इन्फेक्शन?
No, actually, during infection, suppose already inflammation is there, then erythropoiesis is suppressed. Okay, inflammation during active infection, erythropoiesis is suppressed. So even if you give iron, maybe it will not harm. Once the infection is treated, the anemia will get corrected. But anemia due to infection will not be corrected by iron. Okay, so you will have to give blood to that patient and treat her infection, but there's no harm in giving iron.
Okay, deworming can be done in which trimester?
Second trimester onwards.
How many cycles of parenteral iron therapy can be given?
So it depends upon what you are giving. If you are giving FCM, single dose is enough. So the lady does not even need to take oral iron after that. But if you are giving iron sucrose, then you can maximum give 5 doses in a week. And so the dose you'll have to calculate according to the formula. What is the deficit? What is the weight of the patient? So weight into 2.2 into deficit, plus you add 1 gram for the stores. So you calculate and then.
There's a very good question. It's making me also think, why isn't the hemoglobin rise faster with IV iron compared to oral?
You know what happens? Theoretically, oral iron absorption could be decided by so many factors. Like we discussed, food, there could be infection. It is not uniform. And however, the speed of erythropoiesis will be same if adequate amount of iron is given. So if whatever physiology you cannot change of bone marrow. So bone marrow will produce if enough raw material is there. ऐसा नहीं होगा ना, वो bone marrow increase हो जाएगा, वो marrow cells को आप if you are giving enough amount, so that is what. I don't know, it has been publicized by the pharma company, and there have been some reports that the increase is faster with injectable irons. But we have seen even with oral iron, it is a very good response. We have certain patients like in heart disease, it is a relative contraindication. Injectable irons are a relative contraindication. So admitted patients, we have given them good oral iron with vitamin C, and we've got very good response.
I
Within
think
2 weeks.
one thing we should understand, oral and parenteral. Oral is, absorption through the GIT. So there is a lot of potential for interaction, iron absorption may be inhibited, maybe taking time. So parenteral is just bypassing this. This is one thing. Then secondly, as she says, it depends on the erythropoiesis. It has to increase the output from the bone marrow. So that won't change much. And when some reports say that the parenteral works better or faster, I think the timing is important. When is it that you are observing this? Initially, you may find that the parenteral is working rapidly, but at 12 weeks, rate of rise will be same.
The
So
rate
this,
limiting step, when the limiting step is the raw materials,
yeah.
then it might be that the rise is increased with parenteral. But when the limiting step becomes the erythropoiesis, when enough raw material is there, then the increase will be according to the rate of
Yeah,
erythropoiesis.
so consider these factors as well. Just don't take it on, face value that parenteral means it would be better or faster. Doesn't mean that, oral can work as well. There's another question on, can adolescent age group girls who are severely anemic can be provided with iron sucrose treatment, or they have to be kept only on iron tablets?
If there is non-compliance, if there is too much of side effects, or if there is absorption is not there, so criteria is same as in pregnancy. So why it is invasive? Why give invasive? If suppose she's not tolerating iron, if she is not compliant at all, then definitely you can give it. But why, if there is lesser harm or something which harms less is giving equal amount of treatment, why give injectable? Suppose she has a reaction, then
Yeah, although it is, the
we
book
had
says it is rare, but whenever it happens, it is a very severe
two
reaction.
patients had such anaphylaxis. They had to be shifted to ICU. Such bad bronchospasm, everything, the whole spectrum in front of my eyes. One iron sucrose.
One case is
Two
enough for
cases.
that matter in your
Two
lifetime.
We had 2 cases. One patient even landed up in coagulopathy and abruption, but when the baby died, but she survived. The other one, in front of me, immediately I gave her adrenaline, and then she was.
So a lot of monitoring is also required. You have to be ready for resuscitation of this patient to manage this anaphylaxis. So all those, so that is why I said there are considerations and caveats that you have to balance both. So these are the caveats. So if you find that it is outweighing, go ahead and do it. You have a patient in front of you, but most of the time, oral is the safer one. I feel
We ourselves would rather take tablet than get injectables.
yeah, true. Regarding your question about vitamin C source taken at any time of the day or to be taken along with iron, pairing
Along with
means
iron.
with iron. Any time of the day, both will be independent. So pairing means at the same time. There is a question about if pregnant mother is anemic, then IFA tablet can be given in first trimester.
She will not tolerate it, and we should avoid it only after 12 weeks, ideally.
एक क्वेश्चन है जो सब लोग on the day of parenteral iron sucrose dose, should we also give IFA oral tablet?
It is supposed to be avoided because it increases chances of anaphylaxis.
एक क्वेश्चन है शायद वो वन पार्टिसिपेंट इज राइटिंग वो जो हीमोग्लोबिन
And
लेस देन
once you
8
have given carboxymaltose, you do not need to give oral iron at all. because it takes care of iron as well as stores. Then you don't need to give iron, oral iron, once you've given enough.
A question,
Complete.
we will review this. Somebody is writing, हमने लिखा ना indication for blood transfusion less than 8 grams at term. So I think there is a concern about that.
37 weeks at
term, we meant the last, after 36
37 weeks and
onwards.
above.
We will see that. Don't worry about that. Anyway, there is one extra question, so we will give you the benefit of that. Anyway, scores are not being considered. It was just an educational exercise to learn. Our endeavor was to give you different scenarios so that you can manage the whole spectrum of presentation of anemia in pregnancy.
So if the patient is having symptoms like palpitation, she is going into failure, in that case we do not have time for erythropoiesis 1 week, 2 weeks. In that case we'll have to give blood transfusion.
Yeah, again, okay, maybe we had to make the question even more elaborate to include this, but the idea was to ask you, blood transfusion has limited indications, so limited situations where you can give this. For drug interaction with tofacitinib, I think I gave you that website, drugs.com, druginteraction.com. This is free. You can enter and see, because not many patients are receiving this tofacitinib monoclonal antibody. So I won't have this ready here. So you have to, refer to a source. I think first trimester में severe anemia, what to give?
So you, in first trimester, try and find out what is the cause, investigate, and if patient is going into failure, she requires blood. Otherwise, start oral treatment in second trimester.
A very good question here. MMR in Kerala is increasing during last 3 to 4 years after reaching 18. What could be the reasons? I think you should be.
What is your cesarean section rate? So cesarean section and repeat cesareans, we are having so much of morbidity because of rupture uterus and morbidly adherent placenta. And increase age at conception, comorbidities, diabetes, hypertension. That is the cause. Most important.
So that is why audit of these cases is also very important. That will give you insights into what's happening over the period. The
maternal mortality audit is being conducted at every facility level, every district level in India, every state, and at national level also. So you find out with your
Dr. Shakun, what I see is, although this is a requirement, when I go for assessment, at least I can share my experience. This remains a document. हमें करना है, हमने वहाँ रेफर कर दिया है, हमने ये, but actually I haven't seen many people going actually into the cause of it. They don't ask why is this happening. So
we need to find out what are the actionables we can do at our facility. Yes. And or at the facility where from where the patient was, what could have been done to prevent it, and so that we can implement it in future cases so that it is not repeated.
The purpose is to find out the cause so that you don't repeat it.
Yeah, exactly.
What happened, also, it is good. It is not that only you will look into the death cases, also look into the near miss cases.
Exactly.
Who just survived despite severe anemia, despite PPH, these patients survived. So you must get to know, what is it that worked in this patient. And then perhaps you can repeat that, doing in for the other patient as well. So it is not only the death audits that you do, which are of course mandatory.
When you have 2 less deaths, you can go for a near miss. but at present we already have, we are having deaths.
That is the minimum mandatory requirement. वो license के जैसे है, for driving you need a license,
Yeah.
but for quality you go for a higher standards. Driving के लिए minimum चाहिए, but if you want to be the best driver, you need to do learn
Exactly,
more.
exactly.
It's something like that. So I think we have answered all the questions. Folic acid should be started at what time in pre-conception?
3 months prior. So when she starts, you should tell her that you take folic acid for 3 months and then plan to conceive.
I think if there are no more questions, we have answered all the questions here. And
I just wanted to say one thing, that doxycycline is also contraindicated during pregnancy. It causes staining of teeth.
मैंने बोला tetracyclines, doxycycline is one
and
of them.
doxycycline both
Yeah.
should not be given during pregnancy.
मैंने time की उससे I didn't go into the detail. Avoid both tetracyclines
and fluoroquinolones.
It
affects the cartilage.
Besides, one is that they are not safe for pregnancy patient, and second, they interfere with the absorption of iron as well. So you have to keep both things in mind. I think we had a long session today. It's past 6 now. Hanji, Dr. Srivastav, we have.
Thanks, Professor Shakun, for patientfully responding to each and every query. This matters a lot. These small things are much needed if we are serious about tackling the problem of anemia. Otherwise, we are going to stagnate.
Actually, the spectrum of anemia is changing. Everybody is becoming aware of iron. So B12 deficiency is getting unmasked. So we just need to take care of that also. We're getting all the women with who have had FCMs and still severely anemic, all turn out to be having a B12 deficiency.
So I think Aman, you can deliver the vote of thanks. And
for that, I think Aman, chat box post test link is there. All of you, please attempt it. Please, जो pre and post दोनों देगा उसी को certificate मिलेगा. नहीं तो नहीं मिलेगा.
Yes, ma'am.
And
also,
we hope to see improvement in score. Pre-test score average was 11 out of 21. So we hope to see some, change in score, improvement in score post-test. Okay.
Also, ma'am, the feedback link is also
feedback भी
posted
जरूर
in the
दीजिए
chat
ना.
box.
That matters to us. This helps us in designing the sessions, addressing topics. You can suggest if you want some, list of topics is given in this series. You must have all got that flyer. Besides that, if you want other topics to be addressed here, we can consider it for the next series.
Thank you so much, ma'am. With this, I would like to conclude this session. I would like to thank our guest speakers, Dr. Pawan Kumar sir and Dr. Shakun Tyagi ma'am, for taking out their precious time from their busy schedules. I would also like to thank Dr. Sangeeta Sharma ma'am and Dr. Srivastava sir, Advisor Quality and Patient Safety. So the next session will be on 15th of February 2025, and the topic would be management of pyrexia of unknown origin and management of fever in young infants. Hope to see everyone on 15th again, and thank you so much. Thank you so much.
Certificate आपको 10 दिन बाद मिलेगा.
Yes.
And you can
They will
access.
be mailed.
हाँ, मेल से आ जाएगा. Only to those pre and post जिनका दोनों pair होगा. Secondly, if you haven't been able to attend the entire session due to your other commitments, YouTube channel of NHSRC Quality and Patient Safety Division has all the recordings available. Even previous recordings are there. You can access anytime at your convenience for this. You can also scan the code given in the flyer. That will take you to the YouTube channel.
Also, the link to the YouTube channel is also posted in the chat box. All the links have been posted in the chat box.
Thank you, Dr. Shakun.
Thank you.
Sparing time.
Thank you, everyone.
Thank you, ma'am.